Hello, my name is Jihan Budak. I have no disclosures, and I will be reviewing the HPTN, or HIV Prevention Trials Network 084 trial, a landmark study of long-acting injectable cabotegravir for HIV prevention in women. As background, the HPTN 084 study was a multinational Phase 2b/3 randomized, double-blind, double-dummy, active controlled trial intended to compare the efficacy of long-acting intramuscular, or IM, cabotegravir to daily oral tenofovir DF emtricitabine, which I'll henceforth refer to as TDF-FTC, as used for HIV pre-exposure prophylaxis, or PrEP, for women in sub-Saharan Africa. The study inclusion criteria were that participants must be women, aged 18 to 45 years, neither breastfeeding nor pregnant, have had at least 2 reported episodes of vaginal intercourse in the previous 30 days, and agree to use of a long-acting reversible contraceptive, otherwise known as a LARC, have no substantial renal, hepatic, or cardiovascular disease, and have a negative HIV test at baseline and negative HIV RNA within 14 days of trial entry, who were deemed to be at substantial HIV risk, which they based on the modified VOICE risk score. The trial was conducted in 3 phases. First, all participants were randomized to one of 2 main arms to either receive active cabotegravir or active TDF-FTC. Those randomized to cabotegravir received an oral cabotegravir 30 milligram daily lead-in, which was used to confirm CAB tolerability before receipt of the injection, which now in clinical practice is optional, for 5 weeks prior to switching to Phase 2. In Phase 2, after that oral lead-in, participants began IM cabotegravir 600 milligrams every 8 weeks, having first received additional doses at weeks 5 and 9 to complete an initial load. They also received an oral daily TDF-FTC placebo pill as well. On the other hand, individuals randomized to the active TDF-FTC arm received oral TDF-FTC daily with an oral CAB placebo in Phase 1, and in Phase 2, in addition to their daily oral TDF-FTC, received placebo injections at the same frequency as was being administered in the active cabotegravir arm. A couple of comments. The fact that all participants received an active medication plus a masked placebo so that neither participant nor investigator knew what active drug individuals were receiving is what made this a double-blind, double-dummy trial. Next, prior to transitioning to Phase 2, in which injections were introduced, participants had to report adequate drug exposure, defined by at least 50% adherence by pill count, and ensure they had acceptable safety lab assessments. Anybody with a missed injection delay of 8 weeks or more after their target visit date was offered an injection reload. And for anybody who discontinued injections, open-label daily TDF-FTC was offered for 48 weeks as a precautionary measure to reduce the potential for HIV acquisition and emergent resistance in the tail phase, i.e., when cabotegravir concentrations are declining after their final injection. This was also the case for everyone in Phase 3, the tail phase of the study, so that after approximately 3.5 years of Phase 2, everyone was transitioned to 1 year of oral TDF-FTC, again to provide ongoing prevention against HIV during the period in which the drug levels of CAB slowly decrease. Here are selected baseline demographics of participants in HPTN 084. Overall, between November 2017 and 2020, 4,878 women were screened, and 3,224 were randomized and included in the intention to treat analysis. I will highlight a few things. The median age was 25, and approximately 50% in each arm was younger than 25 years. Over 50% of participants had 2 sex partners or more, 41 participated in exchange sex, and over 30% had a partner with HIV or unknown status. Of note, overall visit completion was high at 90.3% of planned visits, even more notable given that the time course of the study coincided with the COVID-19 pandemic beginning in 2020. As for results, let's begin with the primary efficacy endpoint of incident HIV infections. With a median follow-up time at analysis of 1.24 years, this graph depicts the number of HIV infections after enrollment, of which there were 40 total. There were 4 infections in the IM cabotegravir arm in the yellow bar, compared to 36 total infections in the oral TDF-FTC arm in the blue bar, and this was a statistically significant difference. After adjusting for site and the group sequential design, the hazard ratio for incidence of HIV was 0.12. There was an 88% lower incidence of HIV with use of injectable cabotegravir for PrEP as compared to oral TDF-FTC. Again, use of IM cabotegravir led to significantly lower incidence of HIV as compared to oral TDF-FTC. And the difference when looking at cumulative HIV incidence per 100 person-years of follow-up was also statistically significant. It's helpful to look when incident infections occurred in the CAB arm. Of the 4 HIV infections, 1 was reclassified as a baseline infection, despite initially being thought to be an incident infection. So 1 of the 4 was a baseline infection, 2 of the 4 never received a cabotegravir injection, and the last of the 4 had delayed injection visits with cabotegravir levels far below the IC90 or 90% inhibitory concentration. Importantly, based on samples from participants in the TDF-FTC arm, in a random sample of 405 participants, adherence to daily oral PrEP was low. Only 56% had detectable plasma tenofovir levels, 42% had tenofovir concentrations consistent with daily use, and 18% had levels suggestive of greater than 4 doses per week. So, not much adherence amongst this group. And this likely describes the difference in efficacy between the 2 arms. Said another way, we know that daily oral PrEP is extremely effective when taken with high adherence, and that missed doses lowers the efficacy. And so the relatively low adherence seen in HB2N-084 with the oral TDF-FTC likely explains why injectable CAB was significantly more effective at HIV prevention than the oral option. Now, what about injection site reactions, or ISRs? They were common and reported in 38% of the participants in the cabotegravir group, as compared to 11% in the placebo injection group, who were receiving active TDF-FTC and placebo injections. Pain was the most reported symptom among 4.4% of individuals, and most ISRs were reported at the first injection, typically beginning 1 day after the injection and diminishing over time. As for resistance, luckily, no major integrase strand transfer inhibitor or INSTI resistance was seen in the 4 infections in the cabotegravir arm of the study. And last, what was seen regarding weight change? There was evidence of increase in weight in both study arms of approximately 2 kilograms per year, but there was no statistically significant difference in the amount of weight gained comparing cabotegravir to TDF-FTC. Now, this contrasts with HPTN-083, which was a similar study but amongst men, in which there was less weight gain among the men on TDF-FTC. That difference, though, is most likely explained by TDF causing weight suppression, not that cabotegravir caused weight gain. And I postulate that that effect or difference was not seen in this study in 084, as it was in 083, again likely due to low levels of adherence to the TDF-FTC, thus not leading to this amount of weight suppression we saw with TDF-FTC use in the 083 study. In conclusion, in the HB2N-084 trial, comparing long-acting IM cabotegravir versus oral TDF-FTC as HIV pre-exposure prophylaxis in women, IM cab was superior to daily oral TDF-FTC in preventing HIV among women in sub-Saharan Africa.
The production of this National HIV PrEP Curriculum Mini-Lecture is supported by Grant U62PS924588 from the Centers for Disease Control and Prevention and U10HA32104 from the Health Resources and Services Administration of the U.S. Department of Health and Human Services. Its contents are solely the responsibility of the University of Washington IDEA Program and do not necessarily represent the official views of CDC, HRSA, or HHS. This project is led by the University of Washington Infectious Diseases Education and Assessment Program.